Dr. Svitlana BYCHKOVA, PhD, Associate Professor of Military Therapy Department at the Ukrainian Military Medical Academy. Please, Dr. BYCHKOVA.
Thank you very much. It's more clinical work than research work, but I hope it will be interesting for you to look at our results. First of all, a literature review about the immune changes during the SARS-CoV-2 infection. The coronavirus disease 2019 has been a global pandemic for more than 2 years, and it still impacts our daily lifestyle. A better understanding of the immunity and its regulation in response to SARS-CoV-2 infection is urgently needed. This slide demonstrates the big number of immune cells, molecules, and interleukins that take part in the fighting against SARS-CoV-2 infection. And here you can see the 3 periods of SARS-CoV-2 infections: the study of normal immune system, the study of the stage of energy, and the stage of hyperactivity. And you can see the 3 types of illness: severe and fatal, severe and survived, and more complicated. So the first stage is a normal or hypofunction of immune response. In the best cases, the innate immunity eliminates SARS-CoV-2 without activation of the adaptive immune system, thus creating a so-called never COVID cohort. Circulating neutrophils were increased in severe COVID-19 infection. No significant changes were identified in the proportion of dendritic cells in patients with mild COVID-19. However, in severe patients, the number of dendritic cells was lower than in mild patients and significantly lower in death than survivors. Plasmacytoid dendritic cells, which secrete interferon alpha, were mainly reduced and impaired in function. SARS-CoV-2 may alter the migration of impaired dendritic cells, so T cells cannot be effectively activated. The number of monocytes was no significantly different between the mild and severe patients. Studies have reported that the number of natural killer cells decreases in the early stage of COVID-19. The researchers in 2021 found that severe patients had higher level of natural killer cells compared with the mild patients at this stage, and similar findings were noted in the comparison between survived patients and diseased patients. These findings may be attributed to the fact that patients' innate immune function gradually declines in the early stage of symptoms onset. In SARS-CoV-2 infections, the activation, recruitment, and resolution of the antiviral immune response involve a highly organized cellular and molecular cascade. This cascade tightly regulates the balance between the virus elimination and immune damage. During virus infection, multiple innate immune recognition mechanisms monitor and defend against viruses. Within a few hours, the innate immune system sends out a rapid antiviral response through type 1 till 3 interferons, cytokines such as interleukin-1, interleukin-18, and interleukin-6, and chemokines such as CCL2, CCL7 to inhibit virus replication. Then adaptive immunity is activated. It was noted that the total number of white blood cells in peripheral blood was normal or decreased in the early stage of COVID-19. It looks like another severe virus infection, influenza type A. Lymphocytes count in COVID-19 patients decreased compared with healthy controls. Peripheral blood lymphocyte levels are lower in patients with severe COVID-19 than those with mild COVID. A great decline is noted in decreased diseased patients than those with severe COVID-19 who ultimately survived. The number of T lymphocytes, including CD4 and CD8 plus cells in severe patients, is lower than in the mild patients. The number of T lymphocytes was lower in diseased patients than in severe patients. The function of T cells is lower in severe patients than in mild patients. The frequencies of HLA-DR and interferon gamma plus cells within CD4 and CD8 plus cells are lower in the diseased patients than survived patients, which indicated that T cells function is lower in diseased patients than survived patients. The B lymphocytes count is decreased. The second stage, we know that it is the hyperactivation of immune response. The number of peripheral blood lymphocytes in mild patients, including T and B lymphocytes, gradually increase. Compared with the mild patients, severe patients' peripheral blood lymphocytes were further decreased, especially T lymphocytes. Compared with patients recovering from severe illness, the expression of HLA-DR and interferon gamma synthesis of CD4 and CD8 T cells was significantly increased in diseased patients, which indicate that the cell activity was significantly increased, and the phenomenon of excessive activation appeared. This stage is characterized by release many inflammatory factors, and they cause a cytokine storm, which may cause a synthetic multiple organ failure and lead to patient death. In patients with severe disease who survived at this stage, HLA-DR expression and interferon gamma synthesis of CD4 T cells increase, indicating the increased activity of CD4 plus T cells, as I mentioned previously. In contrast, the activity of CD8 T cells decreases, and the immune system is not overactivated in severe patients who survived. Natural killer cells, dendritic cells, monocytes, and neutrophils exhibit normal levels of mild COVID-19 patients at this stage. A significantly higher proportion of granulocytes was observed in severe patients versus mild patients. The activation of neutrophils and the formation of neutrophil extracellular trap are related to coagulopathy. In addition, in some cases, the hypercoagulatable state can lead to a cortical necrosis and irreversible kidney failure. In addition, cell function markers such as HLA-DR and CD45 decreased, and cell activity was reduced. The innate immunity of severe fatal patients gradually collapsed. The third stage, after the hyperactivation, comes the stage of energy. After the first and second stages of the patient's immune system's response to the virus can be effectively suppressed if the patient's immune function is effective. Thus, the patient enters the recovery period. If the patient's immune function is impaired, it will enter a state of incompetence, and the patient will not be able to resist the infection and eventually die. The number of lymphocytes, including T lymphocytes, continues to decrease in patients with death. Cell function of CD4 T cells is low, as manifested by decreased activating receptors and increased CD45 receptor antagonist and CD28 expression. The number of B cells, natural killer cells, monocytes, and dendritic cells in severe fetal patients is reduced. The immune system of patients with fetal disease enter a state of immune energy after hyperactivation and eventually cannot resist viral infection. At this stage, the overall immune function of surviving mild and severe patients is gradually recovered. Persistent changes, including subset distribution, cell division, and expression of activation and exhausting of circulating CD4, CD8 plus cells, were observed in recovering COVID-19 patients compared with healthy controls for at least 6 months. At 1 month, the relative proportion of circulating CD4 T cells decreased, while circulating CD8 T cells increased, although both has returned to relative physiological levels by 6 months. The immune function of severe fetal patients gradually transforms into an emergency state, and the number of function of CD4 T cells, CD8 T cells, natural killer cells, monocytes, and dendritic cells is dramatically reduced. So, as a result, one of the most important results is the development of pulmonary fibrosis. The post-COVID pulmonary fibrosis has the same features as idiopathic lung fibrosis, and it is associated with architectural distortion of lung parenchyma, and it also decreased the quality of life, because such patients, they need oxygen therapy for a long time, and they can't do any work without oxygen therapy. In COVID-19 patients, possible sources of injury include cytokine storm due to proper inflammatory response, bacterial co-infection, and thromboembolic events causing microvascular damage and endothelial dysfunction. The renin-angiotensin system is also believed to be involved due to the high affinity of SARS-CoV-2 viral spike protein to the angiotensin converting enzyme ACE2 receptors. This slide also demonstrates the risk factors for COVID-19 pulmonary fibrosis, and among them the gender. The men have more chance to have the lung fibrosis than women. Smoking status, the severity of COVID infection, the admission to the intensive care unit, mechanical ventilation play an important role also in the development of lung fibrosis, and the high body mass index and the predominance of abdominal type of obesity also includes to the risk factors of development lung fibrosis. Direct viral effects, the upregulating effects of the virus on cytokines like TGF-beta1 and decreased oxidative stress have all been postulated. The role of renin-angiotensin system has also been established. ACE2 is believed to have the protective role in the lung fibrosis. The decreased ACE2 expression in turn leads to the high angiotensin 2 levels, and angiotensin 2 is a potent vasoconstrictive peptide directly involved in the development of inflammation and fibrosis, in addition to its role in regulating the blood pressure. Angiotensin 2 also plays an important role in fibrotic process. This includes production of pro-inflammatory cytokines such as interleukin-6 and interleukin-8, production of reactive oxygen species among infected alveolar cells, and activation of TGF-beta 1, which in turn leads to the proliferation, migration, and differentiation of fibroblasts to the myofibroblasts, which with the result deposition of collagen and fibronectin. So problems, what we have after the patient with COVID-19 survived. About 44% of COVID survivors develop post-COVID pulmonary fibrosis. So 1/2 of all patients will have the pulmonary fibrosis in any variants. There is no standardized therapeutic approaches to managing pulmonary fibrosis after SARS-CoV-2 for even this time. Corticosteroids, spironolactone, fibrinolytic, and antiviral agents have been proposed. Patients with autoinflammatory phenotypes may benefit from steroid therapy. Early treatment was well tolerated and associated with rapid and significant subjective improvement in breathiness and objective improvements in lung function in patients with persistent interstitial lung disease after COVID-19. But we can't but mention the side effects of corticosteroids, especially their influence to the blood pressure, their influence to the level of the glucose in our blood, and other negative effects of corticosteroids, systemic corticosteroids. However, a subset of patients do not respond well to steroid, and this patient also are in a great amount.